Welcome to the Mental Health Advocacy Network podcast with your hosts, Matthew McClary and Patrick Kirby. This podcast is meant to be an informative series about what services and supports are available, as well as clearly identifying and discussing the challenges we face in having a fully functioning continuum of care for the mental health system in North Dakota. Today we talk to Dr. Rosalie Etherington, who is the superintendent of the North Dakota State Hospital in Jamestown. Dr. Etherington has been vocal about the need for a new state hospital, particularly about the aging infrastructure and the high likelihood for system failure at their facilities. These and other issues are being discussed during North Dakota's interim legislative session, and we are thankful for Dr. Etherington to share some of her time with us. We hope you enjoy this episode.
So I'm a psychologist by trade and a North Dakota native. Left the state, went to graduate school, started my practice in California, and then came back as a psychologist at the state hospital. Didn't expect to stay very long. Became the clinical director shortly thereafter. And then for 15 years, I was the clinical director for inpatient services. And then approximately 5 years ago, became the superintendent of the state hospital. So my specialization is in trauma work for adult trauma victims. And I am identified as an expert for assessing sexual dangerousness. So I am in my position for 5 years, and it's a dual role. It's superintendent of the state hospital, and it's also the chief clinics officer for all the human service centers, which makes the system for the public behavioral health system.
Why did you get involved in this type of work? I'm so curious, because I think everybody picks a background for a different reason. I mean, I picked politics, for goodness sakes. That is a crazy thing to do as well. But why this work? Why psychology? Why? I'm super curious.
Well, it wasn't a straight path. So when I was in my undergrad, I really anticipated becoming a psychologist and an FBI profiler. So I was very interested in forensic psychology. So I worked in a jail, worked my way through college, then went off to work for the Federal Bureau of Prison for a couple of years before I went to graduate school. During my tenure with the Bureau of Prisons, I learned a lot. My eyes were open to the world of forensics, and I ended up out in Los Angeles, opening up the federal jail, downtown Los Angeles. And at that point, started then applying for graduate schools, still anticipating that I would do forensics. But then in my graduate school years and all of the work that I did in community mental health really turned me toward working with people with severe mental illness and trauma disorders. And so the rest is kind of history. I finished my degree. I started working in San Bernardino County, California, working for community mental health, and then moved back to my home state, here to the state hospital. And I have, so although my specialty is really trauma victims, my passion is for what's called psychiatric rehabilitation, which is the other psychosocial components of mental illness and how those are equally important as managing symptoms for mental illness. And so it's this combination treatment that I have developed at the state hospital, and we are also redeveloping at the human service centers, because that is what helps people get well, and stay in their communities.
It's a wonderful leap into kind of our general question on the state hospital in general, which is when on earth was the state hospital originally built?
So the 1883 territorial legislature passed a bill to build a state hospital north of the 64th parallel. So mind you, it was still territorial. So North and South Dakota were a territory. There was already a state hospital in Yankton. And the territory legislature said, hey, look, we need another one. So you got to build one north of the 64th parallel. They passed the bill. They hired an Army surgeon by the name of Dr. Archibald. And he then set about supervising the construction, which then opened, the hospital opened for its first patients in May 1885.
It's hilarious to me that even before statehood, that this has been part of the North Dakota history and such a significant importance for the state, for everybody who is here. I'm curious what the length of stay is for patients at the hospital. I know you've got a boatload of data from, again, 1883, but how has that changed over the years or over the decades even?
So dramatically changed. So it used to be, and I would say for likely the first 50 years of the hospital, more often than not, a person would come and they would stay their lifetime. So they would literally live here. Many would die here. We actually have 2 cemeteries of individuals who died here without family, right? And then were buried on our grounds. Over time, that has changed dramatically. So in about the 1950s, when mental health care became much better, and then they recognized that people, in fact, could be treated to health and could live happy, very fruitful lives, then our length of stay continued to diminish and the numbers of beds that we had continued to diminish. Today, the length of stay is rather complicated because it ranges from about 3 days to maybe 165 days with an average of 49 days. However, the median, which is the most common number of days that people stay for treatment, would be about 14 days. So it ranges greatly depending on people's needs. Some are very short, some are a little bit longer. Nobody stays, more than a couple months.
And so I have a question. How is it decided who's going to go to the state hospital and then who would get inpatient treatment in another private facility, which may or may not be located near them?
Good question. So the state hospital serves as the community psychiatric hospital for the Jamestown and the Devils Lake regions. And so individuals in that catchment area and our area as community would come here directly. So they would come, from an emergency room or from a crisis worker from a human service center, for example, that would in fact screen to the hospital. All other admissions from all other regions would only come in the event a private hospital either refused admission or would transfer that individual from their hospital to ours. So approximately 41% of our admissions come from other hospital settings. So we become that secondary hospital when those private hospitals say, hey, look, either we cannot treat this person successfully or we would really like to transfer them, for various reasons to the state hospital.
What are some of those various reasons? I'm super curious about this, why everybody can't be just treated in a private hospital. And again, as a layperson that has no idea the intricacies of sort of the state hospital itself, what would be some of the instances where a private hospital couldn't treat a patient or couldn't be involved or wouldn't want to be involved?
So let's talk first about wouldn't be involved, and then we'll talk a little bit about wouldn't want to be involved. Mm-hmm. And I think it's 2 separate questions, two separate answers. Sorry. So wouldn't be involved or would opt to say, hey, look, this is beyond us, really has to do with that psychiatric rehab that I mentioned earlier. So an acute hospital is meant to stabilize quickly for individuals then to return to their homes. And there are some individuals with very severe persistent mental illness, often multiple illnesses, including substance use disorders, and a very complicated picture that requires a lengthier period of hospitalization, a lengthier period of rehab, sometimes court-authorized medications, because they even lack the insight to know that they need medications. And it's those individuals that would come to us, stay for a longer period. We would stabilize them psychiatrically and rehabilitatively before they return to their community. There are also a set of individuals who, in the throes of their mental illness, are particularly prone to violence. And it's those individuals that can't be managed well in that acute care setting and would also come to us. So we've become specialists in managing the violence in context to mental illness.
So my next question would be, why don't we have regional hospitals throughout North Dakota versus just one in Jamestown? If we do have regional hospitals, would North Dakota be able to get Medicaid money to help with the costs of that?
Good questions, Matthew, and very complicated answers. So I'm going to try to stay on point. So other states have tried this and failed. And Minnesota is our neighboring state. They opened 10 regional hospitals. They have since closed 4 of them because of staffing issues. They have 6 remaining. Of those 6 remaining, those hospitals treat the same individuals that our regional crisis residential facilities treat in our state. So we have 8 crisis residential facilities in the 8 regions, 105 total beds. And those beds are reserved for individuals in crisis, often actively or acutely suicidal or in need of psychiatric stabilization. So again, mind you, we have 8, Minnesota has 6. They call them regional hospitals. We call them crisis residential facilities. They are equal, and they do have Medicaid reimbursement. So other states have actually looked at this, have attempted regional hospitals, and it has failed dismally. And they have in fact closed them altogether, or they opted to do it in different ways. So it seems to me that the specialized purpose of the state hospital, particularly for those individuals are prone to violence or need longer term psychiatric stabilization and rehab, do not do well in that more acute regional, small bed focus because of the need for the specialized care. So I know that is rather a long, convoluted answer maybe, and I'm trying to stay on point. But in my opinion, I think that North Dakota has done a very good job of managing needs locally in local communities, but also then reserving a specialized facility when needed. In addition, we have private hospital contracts. So there is general fund dollars that goes into private psychiatric facilities around our state, 6 different hospitals, for the purpose of treating individuals that don't have coverage that could in fact be treated locally in lieu of coming to the hospital. In addition, our state hospital is actually the second smallest state hospital in the country. So we have really done a good job of only having open beds for that which is needed. And I'll go back to Minnesota. So interestingly, Minnesota has 1,595, so about 1,600 state hospital beds in their state. So from a per capita perspective, they actually have more state hospital beds than we do. And I am including sex offenders in that mix because Minnesota has sex offenders committed and regular state hospitals and forensic state hospital beds. North Dakota has sex offender state hospital beds, and then what I would call traditional state hospital beds.
For the variety of individuals that come to the state hospital, that has got to be a pressure on, sort of the abundance of expertise that you're going to need is overwhelming to my brain. But what's from the variety of individuals there? What's a I don't know, just a typical day in the life of somebody who is a resident at the state hospital? Or is there a typical day in the life of?
So I would say that there is a typical pattern. And what I mean by that is the typical day of somebody that enters our hospital immediately and needs acute stabilization is going to be very different than a person who stays for a longer period of time in that process of stabilization and what their typical day looks like. So part of our focus is that we want to restore as much typical daily living and our way of being during the day as humans over time. So that acute phase of illness might be really for psychiatric stabilization. We're trying to reestablish a daily pattern of living, of getting up at a certain time, eating your meals at a certain time, and then managing the symptoms of illness. And we transition from there into semi-independence, a lot of freedom on our grounds, restoring vocational, spiritual, social, and psychological well-being in then a progressive number of activities and therapeutic therapies and other forms of work and play in the typical day with enough independence so that we can transition back to home.
And Dr. Etherington, you kind of hit on this for a while. So what type of services related to mental health beyond the services related to mental health, how does the state hospital address some of those physical health, spirituality, community connection, independence, all of those sorts of dimensions of recovery? How does the state hospital address those?
So all psychiatric hospitals are required by our licensing and accreditation to pay attention to manage individuals' spiritual, psychological, social well-being. However, in an acute care setting, that takes on a different form, because when you are immediately psychiatrically stabilizing somebody, then they may not necessarily be focusing on their long-term well-being. The advantage that we have is because we do have individuals that remain longer on our campus, then we can help them get through the acute phase into that rehabilitative phase, where we can actually focus on more of that spiritual, psychological, social well-being. What that looks like in the day is that we have a full-time chaplain on staff, in addition to other chaplains that actually come in under contract and provide weekly services in the forms of individual and group therapies. We also do family therapies, both from a spiritual nature and psychological nature. And then, of course, all that vocational and social training that we do. And then we also, as individuals transition, allow inclusion in community. So there are some of our clients, for example, who would go down and they would work in community. They would also go to church in community, or they could attend church on our campus also. And so it's a variety of things, hard to quantify in, a couple sentences, but very meaningful.
Well, with stays from like 5, for 3 days or like 5 months, right? There's like the big giant range of stays. What typically, or typical like conditions are people dealing with when they go to the state hospital? I mean, we touched on a couple of those, but that's a large range of stays for probably a large range of individuals experiencing a large range of issues. What typically does that look like?
So it's important that I likely clarify at the moment that the state hospital is separated into 3 distinct services. And up to now, I've been talking about the hospital setting, which is the inpatient services. So we do have residential services for substance use disorders, very small program. But in addition, we have the sex offender treatment program. Now, the sex offender treatment program is separate, very distinct. Their length of stay is a couple years. So when I'm talking about this length of stay, I'm not talking about sex offenders at all. So when I'm talking about the hospital setting, the range of disorders that we provide services for primarily would be those individuals with psychotic disorders such as schizophrenias, or mood disorders such as bipolar disorders or major depressive disorders that are very severe. Often our clients have dual disorders, so they will also be suffering from substance use disorders. And so we stabilize all conditions, of people coming to us. In addition, we do have, because we also specialize with geriatric patients, psychiatric patients, then the variety of individuals coming to us in the geriatric category of folks would have oftentimes a dementing illness plus behavioral components of that dementing illness, sometimes also producing psychosis and need of stabilization, and particularly those that are most violent.
Is there a common age of each one of the residents? Is there something that's sort of a tie that binds in an age range, or is this everyone, all ages can come and receive help?
It's really all ages. So although we treat only adults, generally we see individuals from age 18 all the way up to 95. And although I would say the larger portion of folks that we serve are going to be in their 40s or their 50s, we have the whole gamut, the whole range.
And just to ask a question, was there a time where the state hospital was serving children and adolescents?
There was. So from the very beginning of the hospital served children and adolescents of all ranges. And it was in 2007, based on the small population of folks that we served, and working with the community to try to meet those needs elsewhere, that allowed us then to close our doors for good for child and adolescent services.
Here's a weird question I have. I'm going to ask the weird questions on the podcast. I think that's my role. Can you just leave if you get there? Can you just leave if you want to, as a resident? Is there like an open door policy, or is there a restricted, you got to be here because you're sent here? How does that work? I'm horribly curious about that.
So although there are individuals that could in fact come here voluntarily, stay and go at their own will, the majority, about 99% of the individuals that come to our campus come involuntarily. So they are committed by the court for care, and therefore they must remain either until the court says they may leave or we say they may leave. And typically the court will in fact recognize that when we say somebody's ready to leave, then the court would say, okay. We work as best we can with those individuals, sometimes with their guardians and families, to come up with an acceptable discharge plan for everybody, so that although people are here involuntarily, they really stay willingly for care, and that this is in fact their care. They are a part of it, and it's important that people, over time, not necessarily immediately, but over time, really accept, hey, look, I really want to be here. I want to finish, and I'm going to move on.
Mm-hmm. So we're going to get into some of the meatier discussions about the conditions at the state hospital, but I was curious, from the perspective of a patient that would be entering your facility, what kind of conditions are people going to experience when they go to the state hospital? In the 1950s, it was not well thought of for the conditions of a lot of state hospitals. So in terms of a modern sense, what does it look like for a North Dakotan that would enter the facility?
Absolutely. So not very modern. So it used to be that state hospitals, well, all psychiatric hospitals for that matter, were built on an institutional model, which was these long, narrow hallways, lots of rooms. They looked like a real old hospital setting and not very conducive to rehabilitation. So really thinking about the idea of psychiatric hospital, which might be different than medical hospital, they really did build facilities for everybody to remain in their rooms, for them not to socialize, for them not to actually rehabilitate. And therefore it looks dark, dingy, long hallways, no natural light, rooms that sometimes almost look like cells, and not very pretty. So a modern hospitals, interestingly, are built on science, which is, and the science would really identify that healing architecture requires openness, lots of natural light, lots of social space, lots of capacity for a patient to interact with other patients, to interact well with staff, and for there to be an environment that reproduces home as much as possible. And our hospital at the moment is the opposite of that. So although we try to create community space, it is really like a whole bunch of little boxes set in a row without natural light, without green space. And the only way for us to get light to our patients is to actually go outside. And not all of them can go outside, right? For lots of reasons. Or if they can go outside, we have to have them go outside in confined space. And so it's also not very natural. It doesn't feel very much like it's therapy. It feels instead like they're confined.
And have there been attempts over the decades or years during your tenure where you have tried to adapt the current facility as it was constructed to be more beneficial for patients?
Yes. So if you could indulge me for a minute, I'd kind of like to go all the way back to 1885. So it was fascinating to me as I did the history of the hospital to learn that Dr. Archibald, although an Army surgeon, right, he had no psychiatric training, so if you think about all of the institutions that came before us in the East, they were all built on what's called a Kirkbride model, which was an institutional model of care. Dr. Archibald had the foresight to look to Europe, to all the newer research, and identified what's called a cottage plan for the original hospital. So the original state hospital was built as a Victorian village and really looked like a couple cottages for people to live in. Unfortunately, right, after that first 5 years, then as the population grew, as some of the needs that they didn't anticipate, such as needs for individuals with violence, Then they started building more institutional-like buildings, and all other buildings that came after were very institution-like, including the current hospital, which was the newest building. 1976, I think, is when it was constructed, 1979 when it was opened. Also still built on that very institutional hospital-like setting. So what we do to try to bring a better environment to our individuals is to actually look outside of the units themselves where they sleep, get them out of the units as much as possible to other space that we've been able to adapt to be more habilitative, home-like, and with some green space. Now, unfortunately, as we go through the acute phases of illness, some of our individuals cannot leave the units, and so they don't get the benefit of that other space until they're a little more stable.
I think that actually, it's a really good transition to this particular question that's been jogging around in my mind with, you're getting ready for them to leave. And so the ideal goal is to never house somebody for life, but what does the transition look like back into the community? If you've got such a setting that's institutional, how do you get an individual who has been there for a few days or a significant amount of time ready to go back into a community that looks the exact opposite of the place that they have been residing for a while?
So the good thing is, if somebody's here only a matter of days, they really don't become what we call institutionalized, which is they don't get accustomed to that environment, and going home is rather simple. It's seamless. For individuals that remain with us for a period of months, then that process of transition sometimes is a little slower, or often slower than we would for somebody here only a matter of days. And so that slow process really looks a lot like inclusion of family, including of other people in their community, including their providers, to identify, hey, look, what is the best opportunity for success? How should that transition look? Sometimes that transition means that we just have a lot of family meetings and then that person goes directly home. Sometimes that means that they might go to a crisis residential facility or a residential facility and then transition home. So they'll go back to their community in another facility and then transition home. Or sometimes we also have a transitional living facility on our campus. And for individuals with particularly severe illness that have really lost much of their capacity for independent living, and they have failed multiple times in community, then we might actually transition them to our transitional living, then into community here, which is working in our local community, working with the Human Service Center, going and socializing in our community under supervision, and then transitioning home.
And so just for myself to backtrack, so with the facilities themselves, what's the capacity for the state hospital? And have you ever hit capacity and, during your tenure? And what do you do when there isn't room for those who need services?
So interestingly, we reached overcapacity just this past weekend. So
oh no. Oh.
And we had not been at or over capacity, I would say, for several years. And there was a period where we were over capacity for months at a time. However, because of the pandemic, we had actually artificially closed a unit, reduced our hospital beds to 75, and have reserved that unit for COVID isolation when needed. And so with those 75 beds, we have been running as low as 65% capacity and all the way up to 95% capacity. And then with admission of individuals that so happen to have COVID, then we had reopened that 5th unit over the weekend, and now have individuals that were treating in isolation, and other units have now gone over capacity because that's necessary. So different than private psychiatric hospitals who may say no, we do not get to say no. So part of the statute, if somebody that's coming here under commitment, then we must take them. A private hospital may take them, we must take them. And so we don't have much of a choice to go over census if we need to. What we do if that happens is on a temporary basis, we would add beds. So although not ideal, we are allowed under our license to add beds in an acute way, knowing that we need to get back to our census very quickly. And what we would do to get back to our senses very quickly is really look at that period of discharge, and we might hasten discharge, rapid discharges for the individuals that have been here to free up beds for people coming in the front door.
Following up to Matt's question, because I think this is an interesting one too. Have you found that this pandemic, the stress that goes along with it, the uncertainty of everyone's life, regardless of what situation you're at, have you seen an uptick in services needed, uptick in services that you are rendering, the need for capacity and your services at the state?
So at the beginning of the pandemic, and for probably approximately 9 months we actually saw a decrease in the request for services. So there was a decrease in admissions. There was a decrease in people seeking care in community. Then after that period of 9 months, then we started to see a gradual incline and then a very steep incline. And now I do believe that not only in community, but here in the hospital, we've seen a dramatic increase of admissions, increase in need. Our human service centers are assessing more people through the front door than I believe they have in years. And people are coming in very ill.
Is it relatable to what I would imagine is the trauma of living through a pandemic and not having immediate access to services while, sort of in lockdown, and you're trying to deal with this yourself, and it's just not, I can't imagine it working well. As somebody who, 3 kids and a job and that kind of thing, that's a stressful life in general. And on top of an isolation with, access to, practically nothing.
So I do believe that the isolation of the pandemic has really adversely affected all of our mental health. And for those that were already struggling with behavioral health disorders, then that compounded the issues. And then in addition, for individuals that we had been serving with very severe, persistent mental illness, they avoided care during the beginning of the pandemic, right? They were afraid to go to care. They were afraid to get service. And unfortunately, then when they went without service, absolutely things compounded, things worsened. So now their complicated illness that was already difficult to manage became unmanageable, and often then ended up with them, seeking crisis care, emergency care, and ending up in the hospital.
What does the transition look like back into the community? If you've got such a setting that's institutional like, how do you get an individual who has been there for a few days or a significant amount of time ready to go back into a community that looks the exact opposite of the place that they have been residing for a while?
So the good thing is if somebody's here only a matter of days, they really don't become what we call institutionalized, which is they don't get accustomed to that environment, and going home is rather simple. It's seamless. For individuals that remain with us for a period of months, then that process of transition sometimes is a little slower, or often slower than we would for somebody here only a matter of days. And so that slow process really looks a lot like inclusion of family, including of other people in their community, including their providers, to identify, hey, look, what is the best opportunity for success? How should that transition look? Sometimes that transition means that we just have a lot of family meetings and then that person goes directly home. Sometimes that means that they might go to a crisis residential facility or a residential facility and then transition home. So they'll go back to their community in another facility and then transition home. Or sometimes we also have a transitional living facility on our campus. And for individuals with particularly severe illness that have really lost much of their capacity for independent living, and they have failed multiple times in community, then we might actually transition them to our transitional living, then into community here, which is working in our local community, working with the Human Service Center, going and socializing in our community under supervision, and then transitioning home.
And so to just for myself to backtrack, so with the facilities themselves, what's the capacity for the state hospital? And have you ever hit capacity? And, during your tenure, and what do you do when there isn't room for those who need services?
So interestingly, we reached overcapacity just this past weekend. So
oh no. Oh,
And we had not been at or over capacity, I would say, for several years. And there was a period where we were over capacity for months at a time. However, because of the pandemic, we had actually artificially closed a unit, reduced our hospital beds to 75, and have reserved that unit for COVID isolation when needed. And so with those 75 beds, we have been running as low as 65% capacity and all the way up to 95% capacity. And then with admission of individuals that so happen to have COVID, then we had reopened that 5th unit over the weekend, and now have individuals that we're treating in isolation, and other units have now gone over capacity because that's necessary. So different than private psychiatric hospitals who may say no, we do not get to say no. So part of the statute, if somebody that's coming here under commitment, then we must take them. A private hospital may take them, we must take them. And so we don't have much of a choice to go over census if we need to. What we do if that happens is on a temporary basis, we would add beds. So although not ideal, we are allowed under our license to add beds in an acute way, knowing that we need to get back to our census very quickly. And what we would do to get back to our census very quickly is really look at that period of discharge, and we might hasten discharge, rapid discharges, for the individuals that have been here to free up beds for people coming in the front door.
Following up to Matt's question, because I think this is an interesting one too. Have you found that this pandemic, the stress that goes along with it, the uncertainty of everyone's life, regardless of what situation you're at, have you seen an uptick in services needed, uptick in services that you are rendering, the need for capacity and your services at the state?
So at the beginning of the pandemic, and for probably approximately 9 months we actually saw a decrease in the request for services. So there was a decrease in admissions. There was a decrease in people seeking care in community. Then after that period of 9 months, then we started to see a gradual incline, and then a very steep incline. And now I do believe that not only in community, but here in the hospital, we've seen a dramatic increase of admissions, increase in need. Our human service centers are assessing more people through the front door than I believe they have in years. And people are coming in very ill.
Is it relatable to what I would imagine is the trauma of living through a pandemic and not having immediate access to services while, sort of in lockdown, and you're trying to deal with this yourself, and it's just not, I can't imagine it working well. As somebody who, 3 kids and a job and that kind of thing, that's a stressful life in general. And on top of an isolation with, access to, practically nothing.
So I do believe that the isolation of the pandemic has really adversely affected all of our mental health. And for those that were already struggling with behavioral health disorders, then that compounded the issues. And then in addition, for individuals that we had been serving with very severe persistent mental illness, they avoided care during the beginning of the pandemic, right? They were afraid to go to care. They were afraid to get service. And unfortunately, then when they went without service, absolutely things compounded, things worsened, so now their complicated illness that was already difficult to manage became unmanageable, and often then ended up with them, seeking crisis care, emergency care, and ending up in the hospital.
So we're going to get into some of the meatier discussions about the conditions at the state hospital, but I was curious from the perspective of a patient that would be entering your facility, what kind of conditions are people going to experience when they go to the state hospital? In the 1950s, it was not well thought of for the conditions of a lot of state hospitals. So in terms of a modern sense, what does it look like for a North Dakotan that would enter the facility?
Absolutely. So not very modern. So it used to be that state hospitals, well, all psychiatric hospitals for that matter, were built on an institutional model which was these long, narrow hallways, lots of rooms. They looked like a real old hospital setting and not very conducive to rehabilitation. So really thinking about the idea of psychiatric hospital, which might be different than medical hospital, they really did build facilities for everybody to remain in their rooms, for them not to socialize, for them not to actually rehabilitate. And therefore, it looks dark, dingy, long hallways, no natural light, rooms that sometimes almost look like cells, and not very pretty. So a modern hospitals, interestingly, are built on science, which is, and the science would really identify that healing architecture requires openness, lots of natural light, lots of social space, lots of capacity for a patient to interact with other patients, to interact well with staff, and for there to be an environment that reproduces home as much as possible. And our hospital at the moment is the opposite of that. So although we try to create community space, it is really like a whole bunch of little boxes set in a row without natural light, without green space. And the only way for us to get light to our patients is to actually go outside. And not all of them can go outside, right? For lots of reasons. Or if they can go outside, we have to have them go outside in confined space. And so it's also not very natural. It doesn't feel very much like it's therapy. It feels instead like they're confined.
And have there been attempts over the decades or years during your tenure where you have tried to adapt the current facility as it was constructed to be more beneficial for patients?
Yes. So if you could indulge me for a minute, I'd kind of
Yes,
like to
please.
go all the way back to 1885. So it was fascinating to me as I did the history of the hospital to learn that Dr. Archibald, although an Army surgeon, right, he had no psychiatric training, so if you think about all of the institutions that came before us in the East, they were all built on what's called a Kirkbride model, which was an institutional model of care. Dr. Archibald had the foresight to look to Europe, to all the newer research, and identified what's called a cottage plan for the original hospital. So the original state hospital was built as a Victorian village and really looked like a couple cottages for people to live in. Unfortunately, right, after that first 5 years, then as the population grew, as some of the needs that they didn't anticipate, such as needs for individuals with violence, then they started building more institutional-like buildings, and all other buildings that came after were very institution-like, including the current hospital, which was the newest building, 1976, I think is when it was constructed, 1979 when it was opened. Also still built on that very institutional hospital-like setting. So what we do to try to bring a better environment to our individuals is to actually look outside of the units themselves where they sleep, get them out of the units as much as possible to other space that we've been able to adapt to be more habilitative, home-like, and with some green space. Now, unfortunately, as we go through the acute phases of illness, some of our individuals cannot leave the units, and so they don't get the benefit of that other space until they're a little more stable.
After this great discussion on the history and the current condition of the state hospital, our conversation with Dr. Etherington moves forward, visioning for the future. From community-based solutions to physical building space, the roadmap for mental health treatment accessibility is paved with creativity, positive research, and up-to-date best practices. Dr. Etherington's perspective from a boots-on-the-ground leadership position gives us some insight into why the need is great and what options are available.
So when we started looking at what we had done to our campus to really try to maximize our physical environment to best meet the needs of our clients, we recognized that there was only so much we could do. And then in addition, as we evaluated just the physical the mechanical, electrical, plumbing, and structural facilities of the campus, as we managed our budget, we recognized that so much of that mechanical, electrical, plumbing systems were outdated. So we actually had an expert come in, do a full analysis of every system, every building, every brick, right, every electrical panel in the facility, and then identified for us what was current, up to date, what was nearing out of date, and what was very seriously out of date, and then identified for us on a grid what we had that was most acute, what we needed to fix. And it really came down to 76% of our systems, mechanical, electrical, plumbing, all out of date, some of which was such seriously out of date that they were in jeopardy of failure, that we then sat down with the numbers and said, wow, right? So the cost of replacing all of this and making the facility functional, fully functional, outweighs the cost of a new hospital. Because even making all of our mechanical, electrical, plumbing systems functional, it doesn't actually fix the environment. So we would keep the institutional environment, fix all of these systems. Well, now we would be up to date. We wouldn't be in jeopardy of failure, but we wouldn't have a better place to treat people. A new hospital not only brings us, an up-to-date hospital that now doesn't need new systems, but it would also give us a healing environment that helps people get better faster, that makes patients more satisfied, staff more satisfied. It would be a much better investment for our state.
Well, how old are the current facilities as they stand now?
So
I'm imagining this thing as, I'm imagining the rust in there and that kind of thing. What's the age currently?
Yeah, so rust, mold, asbestos. So the buildings themselves are between the ages of 1918 and 1979. So those are the buildings. Then there is this infrastructure below, some of which has had, partial replacement, some fixing, so on and so forth. But the tunnels themselves date, even longer than 1918. And some of the piping in the structures, date to 1910, 1920. And although we have replaced some water mains, for example, and so now we have a mix of modern water and old water pipes. It's kind of a mismatch, and it's, some of it looks okay, some of it doesn't look okay. I'm just thinking of some of the tunnels I've been in recently, and some of the pipes I've been taking pictures
of. From the perspective of a patient, would they know some of the structural issues that are going on? Would they be able to, deduce all of that information? Or is it primarily that they're not necessarily seeing the structural problems, but they might be aware of the lack of a more modern therapeutic approach to care?
That's a good question. So I think that they would likely not know the structural problems that exist. And particularly the guts of the facility are really, they are locked off for a typical human eye. However, what they would experience likely because of the problems of our electrical and mechanical systems is that their rooms are going to be either too hot or too cold, and they're never really regulated well. Or that somehow, things don't work well always, or things break down on their units, for example, and and then it just perturbs them. What they would typically experience, though, is what you said, which is they're just going to experience the dark, dank hallways, the brick, the lack of green space, the lack of natural light, and feeling as though they are confined. That would be their typical experience. When we have dollars that are given to the facility for upgrading, we typically concentrate on patient care areas. So we let everything else, right? Everything else takes a back seat. So the patient areas themselves are well kept with paint and carpet, for example. But again, you can't create a natural healing environment when you have a dark, dank hallway. You can replace the carpet so it looks a little better. You can use light paint so it looks a little better. It's just not the same as a new facility.
System failure is something we might only attribute to aircraft, cars, or politics. But critical infrastructure like electrical, plumbing, and foundational brick and masonry issues may be impossible to fix in the near future. A simple question about backup plans for the current state hospital spawned a dozen follow-up queries and lays out the Herculean task of maintaining a building with technology almost 100 years old.
So some of what they identified for possible system failure would be our electrical system, some of which is very severely outdated. So an electrical system failure would almost certainly require us to vacate the facility. So although we have electrical backup, so we have generator backup for the facility with the hope that if electrical goes out, then your generator comes in. But because the electrical substation, and I'm hoping I'm getting the words right because I'm not an electrical engineer, but the electrical substation itself is very outdated. So if that goes, right, we are talking systems failure. We are not talking about easy fix. We would therefore have to vacate the campus. And it's really unknown about how rapidly they could actually get that fixed and get us back into our campus.
And so you have multiple buildings. If one building goes, is it like a cascading effect where all the buildings start to go, or do you then have to mitigate the losses of one building by ramping up whatever services you provide in a different building? How does this work?
So all of our electrical, plumbing, mechanical systems are all interconnected. So it's essentially one major system functioning into each of the buildings. So for example, however, if we end up with an electrical failure just in the administrative building, it is possible for us to shut the power off to that building and retain power to all others. If the electrical system itself, however, blows, then that's to all buildings and it doesn't matter, right? So it just depends on where that electrical problem originates. And very similarly, the same with our, fire suppression systems. So although each building has fire suppression and we can turn off fire suppression in a building, all that fire suppression is interconnected. So if at the substation it blows, then they all blow.
Well, if everything goes out, right? So you've got to move people from one place to another. What population groups need to be housed with other populations if this entire failure happens? And that includes sex offenders, by the way. So what does that look like in oh man, everything's going, now we got to move people, and then you're mixing populations? What does that look like?
So if we ended up in system failure and we had to evacuate immediately, our evacuation plan would immediately take all patients, including sex offenders, down to the local civic center. So we would, in fact, go with our staff, with all patients, to the civic center. We would separate as best we can. However, you can imagine that really isn't full separation, true separation of our sex offenders with our other patients, some of whom very vulnerable. And then we would very rapidly start, one, identifying, is this such a system failure that we can get everything back running soon and get back into the facility? But if not, then where in fact could we find places for our patients to go? So we would start with our hospital setting and try to identify other private hospitals who may be willing to take our patients. So then we would start, essentially transferring for that purpose. And then hoping that we could get our patients for the hospital setting placed, and then our residential settings. And then we would turn to sex offenders to say, what would we do? However, as you can imagine, that would take days, if not weeks, to really try to work that out.
So I have a question with that that plan. How many days of a plan is that civic center?
So our evacuation plan and our emergency management plan would give us sufficient supplies, for example, for a period of days before so 3 days before we'd have to say, okay, right, we're running out of food, we're running out of water, we don't have capacity long term. What do we do? So you can, 3 days we need a better plan. What are we going to do? So maybe 72 hours to try to figure out where our, hospital patients could go if we can't, in fact, come back to our campus.
So the plan is a week or less than a week of figuring out what to do in imperfect situation. Is that correct?
Correct.
So when you're trying to reroute people through the existing mental health infrastructure in the state, do we have the capability to serve the needs of North Dakotans that way?
So considering that even at our reduced census, our 75 beds, that more often than not, other hospitals are full or near full, I do not see where we would have the capacity as a state to absorb those 75 patients unless we were to quickly open up psychiatric hospital beds elsewhere. And so I could give the example of our flooding in the 1990.
The 97 flood?
Yes, thank you. The 1997 flood. So when Prairie St. John's had to evacuate their patients, then we identified overnight the acceptance of somewhere like 50 or more of their patients. And what we did then is we stood up 2 units in one of our buildings, which of course was empty. And then they brought their staff with them to actually staff hospital beds. So theoretically, if there were other facilities that could do the same, then we could stand up facilities quickly. It's just that probably the only psychiatric facility that has empty beds is the state hospital because we have empty buildings, or Red River Behavioral, which was a psychiatric facility that closed in Grand Forks this last year. I don't see any other facilities that just have empty units, 25 bed units, 50 bed units open or standing there ready to absorb patients and staff.
And when it comes to this, what your assessment calls alarm conditions or caution conditions, I don't know if it's possible to do an estimation, but what is the relative likelihood of a system failure with the current facilities?
So when you consider that 76% of our systems, mechanical, electrical, plumbing, are out of date, and they are somewhere between the caution and alarm, so they're already out of date, some are in better shape than others, then you end up with, and I do not recall exactly the percentage of systems that we have in what's identified as alarm, but alarm would mean that they are over 125% of their life expectancy and in degraded condition, which means that every day that ticks by, you have a higher likelihood of something going awry. The electricians and the other specialists can't estimate for me, what does that mean? Because does that mean that I have a year from now and I am 90% likely to have a system failure? They don't know, but they can tell me that anything that is there in those categories is borrowed time and therefore could blow at any time. And that the older it gets, the more degraded it gets, then it just is a high probability and you just can't weigh the probability.
I keep thinking about the refrigerator that you buy in like 10 years in one day after you buy it. That thing is totally useless. And and I can imagine some of these pieces within the facility are so old that it is a challenge even to find replacement parts. And I know brilliant electricians and brilliant plumbers, but I'm imagining that the systems that they have put together, that's a Google search of the highest order in order to find parts that fit the systems that you have in the basement currently.
No, I'm chuckling because absolutely. So I am told by my plant management team that they are regularly searching the internet, having to order parts from overseas because parts are no longer made. So now they're looking for used parts, old parts, wherever they can get them for some of our systems. Yes.
And so I'm just thinking too, not to say that we could face this situation or we will face this situation, even though it's a possibility. But during the pandemic, if there was to be a system failure, let's say during the pandemic and during the winter, uh, you have a system failure, then you have a supply chain issue. If you're having people ordering parts overseas, there could be a nightmare scenario. Maybe the likelihood is not that strong on that kind of a nightmare scenario, but I'm just thinking of all the really bad situations that could develop.
Well, it's not even a nightmare scenario in this case. Yeah, it's some parts, but then you've got full hospitals from pandemic on top of a systems failure with looking at parts. And so that's the curious double nightmare scenario, or the perfect storm. If you have full capacity hospitals, which currently we do, and there's no end in sight for there, and a systems failure at the state hospital. Now, where do you go and what do you do? And is there a game plan for this gigantic, everything has gone wrong at the same time scenario that you have planned out?
So theoretically, the backup plan to the backup plan would be not ideal, but that we would literally have to relocate all of our patients, residents, and staff up to the developmental center, where we would have empty buildings that would still have power. So again, backup plan to the backup plan. If on an emergent basis we couldn't repair, then that is what we'd have to do. You could imagine taking a set of individuals, our sex offenders who are in a very secure facility, our hospital setting, which is much more secure than residential settings, then relocating them to Grafton. Grafton, the LSTC is not a hospital setting. And so we'd have to, retrofit, do the best we can to manage care. And it would not be easy. Not at all.
And just from personal experience, Patrick, a lot of evacuation plans in emergency situations rely on LSTC, and you could end up creating trauma as a result, because a lot of people had been in that facility. And just in case listeners don't know, that's the facility that was subject to a federal lawsuit in 1980. And there was a number of instances where people with disabilities are kind of traumatized by that concept of going into that building. But so not always like the happiest of thoughts either.
Well, no, but it leads to that. I think the question, and Matt, you brought this up earlier too, was there's Dr. Etherton, you did as well, which is this cost scenario, which is what's the difference between repairing everything at the state hospital and building a brand new one, and the weight of those numbers. And again, I know that it's not taken lightly in any sense, because dollars are dollars, but there's got to be some sort of weight that you put on what do you do to repair and what do you do to build new, and what's the cost difference between repairing and building new?
So the estimates that we had made, and again, they're now a couple years old because we started this process of evaluation about 4 years ago. So the cost to repair at that time, just of the systems that were outdated, now this is no renovation, it's just the systems replacements, would have been an approximate $140 million to $160 million. The cost for building a new hospital, and again, that is dependent on how it's built, the type of architecture chosen, and of course, the size, the number of beds, would be likely somewhere between $140 million to $170 million. So when you just compare those costs alone, those immediate costs are relatively the same. What you get with one is you get new systems, still old buildings, and not necessarily a therapeutic campus. With the other, you get a new therapeutic modern hospital plus all new systems. And what you also get is one hospital building instead of 4. So mind you, we have separate services in 3 different patient care buildings and an administrative building. So you get a replacement of a 1-building hospital that is now much more efficient, much more staff efficient, very, very therapeutic for patients, or you remain in 4 old buildings now with new systems at approximately the same cost. And depending on what they run into as far as asbestos or other things, maybe even more of a cost.
So if a new state hospital were to be built, we touched on this earlier. If a new state hospital were to be built, how would the environment be different and modernized for evidence-based practices?
So the new modern design of psychiatric hospitals really centers around communal space, openness, lots of natural light. So we are talking about lots of safety windows, lots of garden space, and lots of communal areas. And so in psychiatric hospitals, it's very important to recognize that individuals in acute stages of illness, sometimes acutely suicidal, sometimes prone to violence, then the observation of staff with patients at all times is vitally important. And therefore, hospitals often built in around or built without blind spots. So there are no places for individuals to hide, so to speak. But also then, as there is line of sight everywhere you go and things are light and there is green space, then people just get better faster. They heal faster. So the research is very clear that individuals with depression, for example, or bipolar disorders end up in hospital stays for at least 3 days less than they would have otherwise in an old hospital. So just that alone, knowing that the natural light and the better environment hastens the recovery is reason enough, I think, to build a new hospital. Then in addition, you get the patient and the staff safety measures that come with the new hospital that compound the benefits, even beyond just the days of less hospitalization.
I can also imagine that from a staff experience, right? So making sure that you can recruit and you can retain and you can keep staff in an environment in which they know that they're doing good work, but then they can feel like they're doing good work is almost as equal as important as the patients that you are serving. And maybe you can talk a little bit about what those healing architecture environments do from a staffing standpoint as well. Because I just imagine working in an environment like this is so unbelievably stressful. This is going to help.
Yes, absolutely. And I appreciate the fact that you recognize how stressful it can really be. So it's interesting, the research supports that in a new healing architectural hospital, staff satisfaction increases, right? Their job longevity increases. The retention, so the recruitment of staff is easier and the satisfaction of staff is better. And what that all equals to, of course, is when staff are satisfied and staff are happy, then they give better care, just very naturally. So already with a better environment and patients getting better faster, staff are more satisfied, everybody functions at their best. And much of the research around issues of violence in hospitals and violence in psychiatric hospitals and emergency rooms. So healthcare providers in psychiatric hospitals and emergency rooms suffer more violence at the hands of their patients than any other medical environment. And it is often because of those acute phases of mental illness. Interestingly, in new hospitals, violence is reduced by at least 25%. So not only is everybody more satisfied, they are happier, people heal faster, but there's also less violence and less prone to violence.
Well, also in the retention of staffing, I mean, everybody who has a business background too, the amount of money it costs to recruit and hire and onboard is exponentially more than it is to retain wonderful staff. And then retention of your staff is making sure that they exactly know how the environment helps, who they're helping. They know their patients better. They know their patients longer. So again, to your point, that care is exponentially better from a staff who's been there longer and are happier.
Yes.
From expansion to the west side of the state to community crisis services, and a seemingly innocent question about barbed wire sparks a fascinating conversation on the stigma of mental illness and what possibilities are ahead for the state of mental health services in North Dakota. Dr. Etherington shares her thoughts on the capacity of the current state hospital system and shares her thoughts on what she'd like to see created as part of a new building and the environment it would produce through simple architecture, tweaks to programming, and what that means for anyone who comes through the state systems and what challenged with a mental health issue.
So I'm going to delve into kind of an interesting situation and discussion in our state. Over the last, since had graduated high school, a lot of stuff has changed in North Dakota, particularly in the western side of the state. And with the oil boom, and the temporary bust, what is the need for services, mental health services, like in the western part of the state? And has there been attempts to think about how to address the needs of people that are living on the western side of the state?
So the new 2021 census just came out, and some of our counties that are growing at fastest pace are out west. So we have a much larger population out west, and yet we have very few psychiatric providers. We have very few providers in general, and then we have no psychiatric hospital beds west of the Bismarck-Minot areas. So we have been in negotiations for a couple years, really trying to identify, one, the need. We know there's a need for psychiatric hospital beds. We are hoping in the fairly near future that we open psychiatric hospital beds in the West. We're also hoping to expand some of the residential facilities in the West. So although we have expanded community-based services, and there are more community-based services out West than there would have been 5 years ago, there really is still very few residential beds, and there are no hospital beds. And then in addition, you have a lack of or a shortage of psychiatric professionals, behavioral health professionals, all in the state. But then you have a more acute shortage in the West. So the efforts that we have had so far was first stabilizing our human service centers in our Williston and our Dickinson region, and trying to staff them to capacity, and heavily recruiting staff into that area, rearranging staffing patterns, and so that we can maximize on essentially paraprofessionals within that environment, and then using a lot of telehealth where we can, both the private providers and us, to get services into that area. So for example, we now have a robust telehealth capacity so that we may assess individuals in any area of our state via telehealth, no matter what human service center that person walks into, so they can immediately be assessed for need, which was not in place 5 years ago. So those are the things that we have done. Still not sufficient. We still need more. We absolutely need hospital beds, because we know with certainty that individuals that need hospital will call around the state, they'll look for a bed. Sometimes they are escorted to that facility. By the time they get there, then they're told the bed is no longer available, right? And then they're without a bed. Sometimes they end up back into the local area without help.
So what does that look like from a new state hospital bed plan? The number of beds and the number of individuals that you are able to serve? Because I think the expansion of a project like this, the expectation is like, all right, let's triple everything. Let's triple the size of this entire environment. And then let's keep building until, we can house everybody who needs it. So I'm curious to see what that plan sounds like.
So approximately 3 years ago, when we had the Human Services Research Institute research the needs of psychiatric beds in the state, then at the time we had 278 hospital beds. That does not include the state hospital. So the state hospital was at 100 beds for the inpatient services. We had 278 private psychiatric beds. Since that time, Red River Behavioral Psychiatric Facility in Grand Forks is closed. So that has now reduced the beds by 50. What we had anticipated when we went in this last session was to request the building of a new state hospital for inpatient services at 75 beds, with the expectation that we would add at least 10 beds in the western part of the state. So through that research that occurred, they really believed that based on all the hospital beds that were available, the addition of 10 beds in the west could in fact reasonably then reduce the state hospital to 75 beds. So although we did not get approval to proceed, we now stepped back. They are having a consultant look again. And I hope that everybody at the table has healthy conversation about what are the bed needs of this state. So I don't exactly know the answer to that. I'm hoping I'm going to be a part of that conversation. I am concerned that we closed beds in Grand Forks and we don't have those beds available in the state. So does that mean with the addition of our beds in the West, could we still reduce to 75? Yet to be known. There has been an increase of complaints of people waiting in the emergency rooms for care. Sometimes when beds are full and they cannot find care, there have been complaints about that also. It's just unclear at the moment how severe of a need that is. And we need some answers. We need to really evaluate. I'm hoping we did get approval this last session to create a bed management system. So there are other states who have done this, and it's essentially a computer-based system that hospitals would report their beds and their bed capacity to, so that at any given time in the state, we would know what beds are full, what beds are empty. And we hope to actually create and get that system in place with voluntary participation of hospitals and residential facilities, so that we could better evaluate at any given time in our state, are our beds mostly full, which would be indication that maybe we need to add some, or is it the mix of beds that are at issue? And do we essentially just need to either move beds around or change the types of beds we have?
And
so although I didn't answer your question specifically, I apologize, but I'm not so sure we all know the answer to that at the moment.
And so from a high altitude angle, the discussion is around best practices, and best practices are pretty established that we need community-based services so the vast majority of people can receive services in their community. And while experiencing a crisis, certain individuals would need more intensive care. And so the Human Services Research Institute report that you had mentioned said, quote, in contrast to the data, however, there is a perception among some stakeholders expressed in interviews conducted for the state hospital or for the hospital study that capacity is inadequate. The reason for this perception, we believe, is not due to a shortage of beds, but rather to an inappropriate utilization. That is, beds occupied by people who could be served in low intensive settings. So that's their argument is that we need more community-based services instead of relying on people to be treated with beds, quote unquote. But there is still that very public perception that we need beds. And so I was aware of, when we were discussing the construction of a new state hospital, that a number of stakeholders, including law enforcement, might have been really concerned about a perceived reduction of beds because they might be carting people around the state trying to find a bed. So I was wondering, just from a broader perspective, how do you try to address some of those concerns that the public might have about the bed count in the state, and how do we properly utilize bed counts?
That's a very good question. So I think some of the answer has to do with bed management. So until we actually have a system that could tell us at any given time in the state if there are beds open, if all beds are full, if there is waiting time in the emergency room, then we will only be able to identify the loudest voices in the argument about what they have concern for. And as you identified, often people will opt for a bed over a different service. So we don't yet know truly, are beds commonly full? The perception is they are, but until we actually have a system that measures it, we don't exactly know. Now how you counter that really has to do with improving the faith in our behavioral health system that we can respond, and we can respond safely without putting people in beds. And what I mean by that is we now have a crisis response system. It really has not been robust in this state. It has been very dismal. And so although we've had 24-hour crisis lines, they have been primarily for, managing trouble or issues for individuals already in care, and really has not been available to all North Dakota residents. So I expect over the next 12 to 18 months that as we respond and we develop the system and mature the system well and respond well, then people will develop faith that when they're in crisis, people come, And when law enforcement has crisis, they know who to call or where to have somebody go for care that's not necessarily an emergency room or a hospital bed. And so that might mean a crisis residential facility. It might mean the local human service center. It might mean those mobile staff actually going into people's homes and faithfully going to homes that then allows people to say, yep, when I call, people come and I can manage this crisis. And when they say crisis is resolved, things are good, and they walk away or they do a warm handoff to somebody else, then I can trust that people are safe and I don't need them in a hospital bed to be safe. That's going to take some time, but I think that's what's necessary for people to now switch, right? Turn their idea that somehow you can actually treat crisis. You can even treat acute suicidality without going into a hospital bed.
And so to kind of transition to that, the state of North Dakota over the last several years is going through a substantial amount of changes with its human service field, both with what was formerly known as the county social service buildings, and now they're going into zones, but also there's a massive effort at trying to build up mental health community-based services. So you had discussed kind of briefly about the crisis services that are being implemented now. I was wondering if you could give like kind of a good overview of some of the community-based services and crisis services that are being developed and implemented, and how this could kind of address some of the concerns of the community some more.
So it's exciting times within the Department of Human Services. So we have social service redesign, which is this large effort to align all social services in a consistent way across all counties so that everybody that needs a service gets a service. And then the other partnership of that is our behavioral health expansion. So we've had Medicaid has expanded their behavioral health service offerings within what is covered under Medicaid. In addition, some of our other private insurances have opened up their offerings of behavioral health services. We have spent a lot of time and effort in unifying communities and expanding private providers available for behavioral health services. And in addition, Free Through Recovery and other community resources that are developing and supporting that non-traditional provider outside of those professional providers such as psychiatrists, psychologists, therapists, those other paraprofessional providers that are good partners to all that group. So with that in mind, we have private providers expanding. We have services that are offered that are now covered under Medicaid and other insurances. And then we have the local human service centers who are expanding their crisis services and are partnering with those other private providers to do very good warm handoff to individuals that can in fact go and receive care elsewhere. So we've had an increase of residential behavioral health beds, an increase of substance use disorder beds. We've had an increase of substance use disorder providers in the state generally. And then the local human service centers have now created and have rolled out that the mobile crisis services and the 24/7 crisis available services. And I'm not so sure I completely answered your question, but I think all of those pieces coming together as a whole not only expands services, expands a variety of services so that people don't necessarily have to sit in a therapist's office or go to a behavioral health clinic to get care, but they can get care in a variety of ways. And it expands the possible set of providers even in our rural communities. It gives people opportunity to get crises met, to get regular services met, and to even prevent individuals from actually experiencing severe mental illness because they're going to get services faster. All of that working together over time could then diminish the need for the highest level of care, which is psychiatric hospital beds. Now, HSRI had warned us, right? You don't take one away without the other, right? And you wait until that is achieved before you consider, do you have the number of beds you need? Can you reduce the number of beds in your state? their recommendation to us was, hey, look, you have enough hospital beds. You really don't need more, but you really shouldn't be talking about less either until you know you don't need any, you don't need any more, or you need less, if that makes sense.
Mhm. And I guess I did have a question to kind of, it breaks up the flow of the conversation just a little bit, but um, when it comes to what people see when they enter your campus currently, uh, to me, it seems like when I drove in, um, I couldn't help but notice the barbed wire.
Mhm.
So, could you briefly explain about the barbed wire and why it is there?
So by all means, the barbed wire is not part of our hospital, but in the middle 90s, based on the fact that the state hospital was a much smaller facility and we had empty buildings, the legislative body identified the need for another prison, and so therefore we gave several of our buildings to the Department of Corrections, and they opened up a medium security prison on our campus. So the barbed wire, which I think encircles 8 or more buildings, I believe now at this time, actually looms larger than our hospital itself. And the barbed wire is very intrusive, and it's impossible not to see from any area of our campus. So, for example, I look out my window and I see barbed wire. Our patients look out their windows, they see barbed wire, and it is unmistakably a prison. The unfortunate events around that is that because that is what's obvious on our campus, people will often mistake us as a prison. And we are not. We are a hospital.
As we wrap up our conversation with Dr. Etherington, we're excited to announce that future episodes and interviews will be informative about what services and supports are available, as well as clearly identifying and discussing the challenges we face in having a fully functioning continuum of care for the mental health system in North Dakota.
If you had a magic wand, I'm going to give you permission to imagine a magic wand, because you're boots on the ground. You see this every day. You know what the crisis looms. You know where crit failures could happen. You know all of this. If money wasn't an option, if you had the ability to create your ideal state hospital, what would you like to see? Both maybe even in physical form, or just what you'd like to see as an end game to being available to the state. What does that look like to you?
What it looks like to me is, in fact, a new hospital. But the hospital would be designed with the newest research in mind that literally ends up as a circle and a lot of green space in the middle. And so that the clients that we serve could experience their healing in a lighted environment with staff surrounding them and participating in a typical day, just like the rest of us, in spite of the fact that they're in a hospital setting. And what that means is that even though they would have lighted, beautiful sleeping quarters, they would actually leave those quarters. They would go to an area of the hospital that really mimics a community. And that in that community, they could get all of the care they need for that typical day, and they could socialize, and they could work, and they could live and get well before they return back home. What it looks like in Europe, and what I've actually seen in Europe, is a beautiful campus that looks a little bit like a cross between a college campus and a Victorian village or a village, and that people come and go freely within that campus, so they are not confined, and they actually can go and have choice about where to go during the day and get their care, and then they come back to their home at night to sleep.
What I love about this conversation is that it has always come back to the idea of being person-centric, without you saying person-centric at all throughout this entire conversation. It is unbelievably personal. It's unbelievably acknowledging that regardless of mental health status. Therein lies a human being that has gone through whatever significant trauma they have gone through, and that the environment that they get to heal in should be as welcoming and warm as the environment that they deserve. And that's what I think is interesting when the conversation comes up to money and dollars and whatever. The insistence that you continue to highlight is that these are people. There are people who staff it. There are people who are living here. There are people that are going through different sort of experiences throughout their life, but they're people. And that as a person who, or as a body, or as an entity like the legislature, and understanding that these are individuals like your neighbors and your cousins and your nephews and your nieces, they're just like you. And that insistence that this, sort of breaking down this sort of institutional like barrier and providing an environment that is warm and welcoming and healing is of the utmost importance. And that cost is less than rebuilding or, sort of restructuring what you've got currently, and that the long-term health of not only the state hospital, but the individuals who are there is priority number one. And I think that I appreciate that most out of all your responses in the conversation today is that is priority above and below.
Thank you. Yes, it is.
It's good practice for the interviewers to ask the interviewee, was there something that we missed? So what other information, if you have any, would you like to add about the need for the new state hospital?
You guys have been very thorough, but if I had to say one more thing, I think I would reiterate the fact that in my opinion, and this is my home state, so I have lots of pride in my state, but in my opinion, I compare our state to many other states and the efforts that they have had and the ill-planned ways that they have actually tried to right-size beds or close state hospital beds. And in my opinion, we as a state have done it well. And we've done it in ways that have been progressively adding community resources, private providers, expanded communities services, while simultaneously, slowly, methodically identifying the number of state hospital beds and reducing our size. So this hospital today is actually less than half the size of when I came in the 90s. And yet we serve as many people as we did in the 90s. So it tells me that we're doing all the right things, right? People come in, they get well, they leave, they do not stay here. We are serving many people, but they do not remain. And that's the right way to do it. And so, nevertheless, I believe that we do need the state hospital. I believe that we're good partners with our private providers and that we are a specialized facility and the state needs us.
You're fantastic. Thank you so much for this. I really do appreciate your insight and your sort of explainers from the 101 to the super advanced sort of understanding of the need for a new state hospital. Couldn't be more happy that you're at the helm leading this as well.
Thank you very much. Thank you.
Thank you. This podcast is brought to you by the Mental Health Advocacy Network. MHAN advocates for a consumer, family-driven mental health system of care that provides an array of service choices that are timely, responsive, and effective. Our vision is for every North Dakotan to have access to the right service, whether it be preventative, treatment, or recovery, at the right time, when the service is needed, and at the right place, as near his or her home as possible. To learn more about MHAN, our advocacy efforts, and literature about the North Dakota mental health system, visit our website at www.mhan.org. Again, our website is www.mhan.org.